attention. Thank you, sir. Where's the woman from Australia? Oh, you a drink? Where's the gentleman from Poland? Where is he? He left. He lost his drink. Oh, there he is. And where's Greece? Oh, he disappeared. Okay. All right, everyone. Are you ready for your next speaker? Please welcome to the stage Dr. Thomas Santucci.
That was excellent. Whoops, I'll do this. Which is that makes it go forward.
Yeah, you're all set.
Okay. All right, I used to look like that. That was probably 10 years ago. Today we're going to be talking about Alzheimer's disease, and it's kind of antithetical to talk about diseases in an anti-aging conference, but you're going to see that neural regeneration is probably one of the hugest unmet needs, not only of our patient population, but of you all. And so we are going to be talking about interventions. We are going to be talking about what you can do. Hopefully you come out with some of those giveaways. I'm used to talking one-on-one, 3-hour consults with very sick people. I used to be a strategic planner, so I used to talk to 5,000 people at a time. This is an unusual venue for me. I only have 15 minutes, so I wrote everything down. So forgive me. Yeah. So I've never liked superficial answers. I was born into a medical family with a special kind of right brain aphasia that doesn't accept conclusions that are not well supported. Some of you can identify with that. After graduating with international economics degree from Georgetown, I went into IBM's strategic planning group. By the age 27, I had a $500 million product line, 20 cities, 13 countries. In 1992, I was in a serious car accident that broke my neck, my back, my hips, my knees, also my elbows, that was fun, and my face. Working after 12 surgeries and working with 20 doctors, I was left with strength issues, coordination and balance problems, severe pain, diffuse idiopathic skeletal hyperostosis, that's like severe RA in your back, a couple of autoimmune diseases, and significant loss of my higher order facilities. As a youth, I was competitive in swimming and weightlifting. At age 38, I was experiencing all the symptoms of an unhealthy 80-year-old. I learned firsthand what it was to be a patient with complex conditions that were beyond the current technology. So, on the advice of my surgeon brother, who I asked to fix me, he said, become a doctor. So when I was 45 years old, I did that. Yeah, it was no fun. Studying orthopedics, then functional medicine, functional neurology, and regenerative medicine, focusing on conditions that were beyond the reach of conventional technologies. I learned that the functional medicine diagnostic paradigm with its antecedents, triggers, and modulators were significantly more useful than the basic models taught in school. It was clear that there were small pockets of innovators that had worked out solutions to complex problems that the majority of practitioners couldn't contend with or outwardly opposed. It was also clear that the standard of practice was not incorporating advanced diagnostic techniques, neurologic evaluation, high-tech orthopedic equipment, or anything that worked with energy. So of course, that's where we went. So taking advantage of this technology, we assembled a clinic that has become 90% successful in resolving memory, cognition, and complex conditions. And that will be the basis of my talk today. So we're going to be talking about interventional clinical care. I get it that you guys are brain overloaded. So I'm going to do two things. I'm going to try to do details where that's appropriate. Understand that every one of these slides represents about 10 slides in my normal thing. My normal talks are 2 hours. I'm Italian. I'll try not to talk with my hands, but talking for a short amount of time is a huge challenge for me. So we're going to try to understand what the disease is. We're going to try to understand the patient group, and we're going to try to understand what to do about it. For some of you, this will be eye-opening because you have family members that have neurodegenerative conditions. Some of you have memory loss. Some of you just want to live and age longer. Unlike some of the therapies our worst case therapy costs $20,000. So this is affordable. So we'll think about it. So how big is Alzheimer's? So cardiac disease has gone down 2%. Alzheimer's diseases have gone up 142%. Parenthetically and interestingly, the group of people that has the highest increase in Alzheimer's rates is college-educated white females. So not a poor people disease. One of the things that's happening is as a group like this becomes successful, we get more old people. There is a direct correlation, it kind of sounds facetious, to being dead by being old. So, and we all have to deal with that. I'm 72. I almost died when I was 60. I almost died when I was 45. I almost died when I was 20. 20 high-speed car accidents. So I fixed all that stuff, and I think about death regularly. I know all the statistics on it. I'm trying not to do it. For our patients, we literally are coming in and giving them data because everyone really likes data. We're in the Silicon Valley. My patients are so damn smart. And I always say, the first thing I say is, I'm not smarter than you. I'm kind of clever in some things, but I'm ahead of you in this book. And so what we try to do is to give you a rational human being tools and something that we can scale at this point. So one of the things that's true is we're not spending less money on healthcare. We're spending an enormous higher level of money on healthcare. So in 20 years ago, we were slightly over $2 trillion. The projection for next year, 2 years from now, is almost $6 trillion. If we say conservatively that neurodegenerative conditions are 5% of that, and I think it's more like 15, we're talking about a $500 billion market. So for the people here who only see dollars, there's a lot of money to be made here that isn't being addressed. This very busy slide. So like I said, we're going to try to understand the disease, then the patient, and then interventional strategies. In order to affect any medical condition, you first must investigate its etiology. So in regular medicine, that means you have to disregard the word idiopathic. Idiopathic should not exist in medical terminology. Anyone know what that word means? Yeah, and it's worse. We not only don't know what it is, we're not going to try to find out. Can you imagine a physicist saying that? Oh yeah, infinity, way too complicated. Not doing it. Doctors say it and then act like they said something. It's insane. So we first saw that with women with thyroid disease. Yeah, way too complicated. So then we did 6 different levels of thyroid cascade and figured out exactly what it was. So 10 years ago, we made a chart that basically was the triggers that affected autoimmune diseases. We made a list with like 12 things. For purpose of the chart, we only did 6. So we did, it looks like the food is causing this. There's just this huge upswell of this. So the food must be in there. So gluten, dairy, egg, yeast, soy was on the list. Then metals. And metals is way more common than you'd think. A lot of the Alzheimer's patients have some kind of heavy metal toxicity. And the hard thing is to march forward when everybody sort of thinks it's nonsense. So you need tests. So every one of these things has a test and you react to the test. Our metals test regularly come back with arsenic, lead, mercury, titanium, like you name it. And a lot of the metal toxicity, which you can actually see on a patient's skin, is underdiagnosed, completely underdiagnosed. Nobody does the test. Nobody can look at the patient and see it. Obviously, hormones are in there, and that's going to really play a role in Alzheimer's, pesticides and poisons. And when we updated this for Alzheimer's, we made this bigger list or different list. We get the environmental toxins and metals, but they're way, way worse. So there's something called endocrine disrupting substances from xenobiotic estrogens. Think about what that means. That's every kind of perfume. So your laundry detergent, your actual perfumes, cleaning products, everything. You don't want the lemon scented pledge. That stuff is poisonous. And it begins to give us a smoke and fire for why is this twice as much in women? Because of the estrogen predominance. So one of the things that happens when you're doing interventional clinical work is you can't wait for all the research. You have to have working models. So my working model is that these xenoestrogens are causing an estrogen problem, and I'll measure the estrogen, and I'll see a disaster every single time. I'll also look for metals. I'll also see if there's an unrealized disease. All of these things change the neurotransmitters. An important concept is that there's a causal and a feeding relationship between some of these things. The amyloid beta deposition is worse in the presence of inflammation, and it makes inflammation worse. So you have to kind of do that in your brain. And then it cuts down on the mitochondria, which doesn't like the inflammatory thing. It doesn't like the deposition of amyloid. The tau protein is the third thing that comes into a cascade and completely makes the brain environment unhospitable. So in Alzheimer's, we know there's cellular damage. So we see the the normal testing where you're going to do a CAT scan or an MRI, and you're going to see the degradation of the lobes. You're going to see cerebrospinal fluid taking up too much space. You're going to see white in the thing, and that's too late. So yeah, you have a very fancy $3,000 test that says you can't do anything. So what we want to do is test way before that. A thing that nobody really talks about, COVID has become the new immunization talk. If you even say the word, you're in trouble. So apparently COVID never happened, but we're dealing with post-COVID syndrome now. But I don't think it helped anything. Let's just put it that way. So the difference between this 10 years ago and that 10 years ago is COVID. So I'm not going to go into this a lot because for one, this has been beaten to death. I actually like the amyloid deposition and tau protein destruction, at least as an atmosphere thing, as an environmental thing for Alzheimer's disease. All kinds of people are saying all kinds of other things. I don't think Alzheimer's is type 3 diabetes. What does that mean? That I literally have 2 minutes left? Is that yes? We're really in trouble. Okay. So those are the things. I'm going to go through this. When we're doing a clinical assessment, this is a neurotransmitter test. This quantifies the brain chemistry. If you look on this thing, this is a healthy 60-year-old. He basically has no neurotransmitters. Well, he thinks he's fine. So that's a new post-COVID finding. And I'm happy to talk in more detail on this. Brain mapping gives us a neurologic basis to basically quantify neuropsychological concepts. Brain maps are one of my favorite things in the world to understand what's going on. Everybody thinks they've got a handle on how your brain works. None of us have a clue till you do one of those. That's a $600 test, not a $3,000 test. That was my thing. I'm going to skip. This is a neuro exam. Only about 10% of doctors can even do this, and less than that actually do it. That gives us actual neurologic interventions that we can do on a patient base. I'm going to skip all this. That's everything. That's a patient write-up, interventions. So we're using red lasers to go into mitochondria and change the complex 1 and 2. This is a new thing. So a lot of discussion about neural inflammation, a lot of discussion about mitochondria, a lot of discussion about autophagy. We're basically in a position now that we can change those things. The problem is nobody thinks we can. Regular science is probably 10 years behind this. Red light is nothing compared to this. A modulatable laser, 635 laser is nothing compared to this. Yeah. All right.